Hello, I'm Dr. Mani, and this is the third session of the surgery practice of the postgraduate medical entrance test. This is the continuation of the two previously uploaded surgical question answer session practice, for which you can visit the youtube.com/acpgmed channel. You can also log on to facebook.com/acpgmed and get the previous links of more than 70 videos which have been uploaded since December. Please use the freeze button of the video if you feel that the video is running faster, because the YouTube allows only less than 15 minutes of high quality video. So please visit my channel youtube.com/acpgmed. The first question of this session, this is the 13th question of the surgical session. A 78-year-old man with a history of coronary artery disease with an asymptomatic reducible inguinal hernia requests an elective hernia repair. You explain to him that valid reasons for delaying the proposed surgery include 5 options: coronary artery bypass surgery 3 months earlier, history of cigarette smoking, jugular venous distension, hypertension, hyperlipidemia. So which option you will choose? Mark it. Let us see the answer. It is the third one, that is jugular venous distension. The work of Goldman and others have served to identify the risk factors for perioperative myocardial infarction. Highest likelihood is associated with a recent myocardial infarction. The more recent the event, the higher the risk up to 6 months. It should be noted, however, that the risk never returns to normal. A non-Q wave infarction may not have destroyed much myocardium, but it leaves the surrounding areas with borderline perfusion, hence a particularly high risk of subsequent perioperative infarction. Evidence of congestive heart failure, such as jugular venous distension or a third heart sound gallop, S3 gallop, also carries a high risk, as does the frequent occurrence of ectopic beats. Old age and emergency surgery are risk factors independent of these others. Coronary artery revascularization by coronary artery bypass graft (CABG) tends to protect against myocardial infarction, smoking, diabetes, hypertension, and hyperlipidemia, all of which predispose to coronary artery disease, are surprisingly not independent risk factors, although they may cause the death rate should an infarct occur. They may increase the death rate should the infarct occur. The value of this information and data derived from further testing is that it identifies the patient who needs to be monitored invasively with a systemic arterial catheter and pulmonary arterial catheter. Most perioperative infarcts occur postoperatively when the third space fluid returns to circulation, which increases the preload and myocardial oxygen consumption. This generally occurs around the third post-operative day. Next question, that is the 14th in the series. 68-year-old man is admitted to the coronary care unit with an acute myocardial infarction. His post-infarction course is marked by congestive cardiac failure and intermittent hypotension. On the 4th hospital day, he develops severe mid-abdominal pain. On physical examination, BP is only 90/60 mm mercury, pulse is 110 beats per minute, regular. Abdomen is soft with mild generalized tenderness and distension. Bowel sounds are hypoactive. Stool HAMA test is positive. Next step in this patient's management should be which of the following? 5 options are given: barium enema, upper gastrointestinal series, angiography, ultrasonography, ciliectomy. What's your choice? The answer is angiography. Acute mesenteric ischemia may be difficult to diagnose. The condition should be suspected in patients with either systemic manifestations of arteriosclerotic vascular disease or low cardiac output states associated with sudden development of abdominal pain that is out of proportion to the physical findings. lactic acidosis, and an elevated hematocrit reflecting hemoconcentrations are common laboratory findings. Abdominal films show a non-specific ileus pattern. The cause may be embolic occlusion or thrombosis of the superior mesenteric artery, primary mesenteric venous occlusion, or non-occlusive mesenteric ischemia secondary to low cardiac output state. Majority of 65 to 100% is reported. A mortality of 65 to 100% is reported. That is the death rate. The majority of affected patients are at high operative risk, but since early diagnosis followed by revascularization or resectional surgery or both is the only hope for survival, ciliectomy must be performed once the diagnosis of arterial occlusion or bowel infarction has been made. Initial treatment of non-occlusive mesenteric ischemia include measures to increase cardiac output and blood pressure and the direct intra-arterial infusion of vasodilators such as papaverine into the superior mesenteric system. The patient presented in the question is at risk for both occlusive and non-occlusive mesenteric ischemic disease. If his clinical status permits, angiographic studies should be performed before the operation to establish the diagnosis and to determine whether embolectomy, revascularization, or non-surgical management is indicated as initial treatment. Number 15 of the question, a 30-year-old woman in the last trimester of pregnancy suddenly develops massive swelling of the left lower extremity from the inguinal ligament to the ankle. Correct sequence of workup and treatment should be, 5 options are given: venogram, bed rest and heparin, impedance plethysmography, bed rest and heparin, impedance plethysmography, bed rest and vena cava filter, impedance plethysmography, bed rest, heparin and warfarin, clinical evaluation, bed rest and warfarin. Which of these 5 options you will choose in this case? The answer is second one, impedance plethysmography, bed rest and heparin. This patient has a left iliofemoral vein thrombosis, as evidenced by sudden massive swelling of her entire left lower extremity. Non-invasive venous testing should be quite helpful as the venous obstruction extends above the knee, therefore venography and X-ray exposure are unnecessary. Heparin is the preferred agent because it does not cross the placenta while warfarin does. The vena cava filter is not indicated because there is no contraindication to heparin therapy and there has not been any evidence of pulmonary embolism. The next question, 16. A 20-year-old woman is found to have an activated partial thromboplastin time APTT of 78 and the control is only 32 on routine testing prior to cholecystectomy. Further investigation reveals prothrombin time PT is 13, control is 12. A template bleeding time is 13 minutes. Platelet count is 3.5 lakh. Which of the following characteristics of this woman coagulopathy is true? The first option is infusion of purified factor 8 is usually required to normalize its concentration prior to surgery. Second option is infusion of cryoprecipitate will not be followed by an improvement in coagulation. Third is most of these patients are become seropositive for HIV. Then next is epistaxis or menorrhagia is uncommon. Last option is lack of platelet aggregation in response to ristocetin is a common feature of this disease. Which option you will choose? That is the last option, lack of platelet aggregation in response to ristocetin is a common feature of this disease. Von Willebrand's disease has an autosomal dominant pattern of inheritance that affects both men and women. The deficiency of factor VIII activity is generally less severe than in classic hemophilia, tends to fluctuate even in an untreated patient. However, the bleeding tendency is compounded by abnormal platelet function. This is responsible for common occurrence of epistaxis and menorrhagia. In 70% of patients, platelet failed to aggregate in response to the diagnostic reagent restore setting. The infusion of precipitate provides factor 8 or WF, that is 1 Willebrand factor, whereas infusion of high purity concentrate of factor 8C are not effective. These patients do not generally require treatment unless they need surgery or are severely injured. Therefore, they have not usually received the contaminated concentrate responsible for the 80% prevalence of HIV seropositivity among hemophiliacs. Next question, the chief surgical risk to which patients with polycythemia vera are exposed is that due to 5 options are given: anemic disturbances, hemorrhage, infection, renal dysfunction, cardiopulmonary complications. The intraoperative and postoperative hemorrhage is a significant problem in the patient with the polycythemia vera. Despite thrombocytosis, these patients have a hemorrhagic tendency generally ascribed to a qualitative deficiency of the platelet. Elective surgery should be postponed until the hematocrit and platelet count reach normal level. Alkylating agent such as busulfan or chlorambucil are effective in this regard. In the emergency situation, phlebectomy should be performed prior to operation, and also an especially careful hemostatic technique should be employed. Infection is also a problem in patients with polycythemia vera, but hemorrhagic problems are the more frequently encountered complications. Hope this session was useful to you. Please visit the channel acpgmed in the youtube.com/acpgmed. You can also log on to the Facebook account. Thank you.